So it's a real pleasure to be here and talk about the peripheral and what could be the new standard in peripheral bronchoscopy. So we will check that first. I'd like to present myself. I'm Bruno Escarguel. I'm a local stage because I head the interventional pulmonology unit in the Hospital St. Joseph, it's just nearby 2 kilometers from here. But as you said, Marseille is a pioneer in interventional pulmonology with Jean-François Dumont, who was my master for the rigid, and Christian Boutin for the PRORA. So here is the energy of the interventional pulmonology. So I would like to say about peripheral. Talking peripheral is a real key point because we have a lot of questions, and lung cancer screening will increase the answer to offer to our patient because they will increase the part of nodules, so we have to give answers. So of course, nodules are not only cancer, but all the lung cancer are not stage 4 too. So having a real importance in the diagnosis is a key point. Bronchoscopy treatment are in the pipelines, and we are really collaborative because we help radiotherapists for fiduciary marking and the thoracic surgeon for the pleural markage. And you know that peripheral and radial probe is a success story because the ACCP guidelines recommend the technique till close to 10 years old. So it's a long way. So we had different assistants for bronchoscopy. And for me, my choice is done because if you have a redundant technique or electromagnetic technique, I think the ultrasound was the best thing. Why? Because it's easy technique. It's simple, just 2 probes, 2 different diameters, 1.4 and 1.7 millimeters. We use a guide sheet, and now we have a new guide sheet, really easy to use. It's a system radial, so we have a rotative engine using 20 megahertz for the frequency, and you have the history of the processor because first in 2007 I was using the EUM30, so it was a GI processor. So now we can use the EM2. So the things have changed. So the success story is a long history because it was adapted in the bronchus. First, it was in GI. For the duct of the hepatic duct. So it was adapted in Japan in 1999 for the bronchial war. Then he arrived in Europe in 2002. Felix knows the history, but when the guide sheet was developed, it was becoming a standard for the bronchoscopy peripheral. So just show the video. No, it wasn't working, sorry. So the success story is now still a reality because if you see the last 20 years for the publication, you see that you have an increasing part of the publication about radial probe and peripheral. And I just show you my 10 last years activity. You have an increasing part of the radial probe that follows the increasing part of ABUS. It means the both are the same. You have to do the diagnosis and then doing the staging. So it's a really important thing. So just show you the video because it's an easy technique. You put a mini probe in the channel, operating channel, like a forceps. So it's easy to have an approach of the peripheral with this technique. And still a success story is now a reality because even for new robotic techniques, the radial probe still important to use. So the another part of the PEC for the package for the peripheral is to using thin or ultra thin bronchoscopes. Of course, the ultra thin allows you to go farther, and now we have ultra thin bronchoscope, only 3 millimeters of diameter, and using a 1.7 millimeter operating channel that you can use mini probe or biopsy with a periodic forceps. So you can use it easily and go farther. But even if you go farther, with a new processor of the EV61, you can have a nice part of view of the proximal approach with different technique of chromoscopy, like the NBI or the RDI that help you to see the big vessels, to be sure that when you have a proximal approach, you limit the risk of bleeding, or with the TXI that give you an enhance of the different part of the structure that give you best quality of imaging. So peripheral allows you to have a nice approach for the proximal. But the last point of the pack is the planification. And I think that the key word is shorten the time of procedure, because when you see that first, the labyrinth of our bronchus, you say, okay, it's really difficult to be sure that you want to go where you have to go. So planification can give you helping time, first planning, and then have a pathway, because they give you the opportunity to check the zone where you have to go. Because if you're too proximal and you have to check different zone, you lose time. But if you go and you follow the planification with the pathway, you are sure that you will check in the smaller zone, so you will win time in your procedure. The technology is really easy, and now the pack is included with Vera and Olympus. Okay, so it's a technique that you use the DICOM. Okay, that you use the DICOM of the CT scan. Then you fix where is the abnormality, and there is a artificial intelligence that give you all the lesion in surface and volume, and then they calculate automatically the segmentation, and they give you a pathway. But you have the possibility to change the pathway, or to select another zone. For example, if you have 2 nodules, you can select 2 different nodules, and now you can follow the different ways. For example, here there is a limiting because there is no bronchus way. And you can, after the processing, follow the pathway like a line. And then when you are in the area, you follow the line. And when you are in the area, you can check with mini probe. So you're proximal, then you go farther, you stay on the zone, and with your 1.7 millimeters probe, or if you have a 2 millimeter operating channel with a gauge sheet, you can check and select the zone and then biopsy. So there's an evolution of the technique, because you can add different sensors to give you a real-time navigation, but you can have different tools, steerable tools, that can allow you to have more diagnosis, more reachability for the lesion. So this is a big pack, including mini probe, ultra-thin bronchoscopes, and the planification. So this is the real time for the diagnosis, but the opportunities to enlarge the part of diagnosis is first to be collaborative, as I told you, to help the radiotherapist to putting fiducial marker, or to help the thoracic surgeon. For example, for the GGOs, you have to help him to say, okay, go on this way, so you can do a plural marker with the blue methylene or the green endocyanin. And I think the next step will be the future for the therapeutic. It means using radiofrequency or microwave or the steam or different technique could be a solution for patient non-operable. So say we have hands, but with our hands we can accomplish wonderful things. You have a lot of things in the world that you say, okay, with hands you can do a lot of things. So I would like to thank Olympus first to be here and have to discuss about the peripheral, and then to give us the opportunity to be more comfortable for the peripheral. Thank you very much.
Bruno, thanks a lot for showing us what is possible nowadays. Are there any questions? If you have questions, just come to the mic and identify yourself. So maybe let me start. So you have a lot of money, so you can buy Veran, you can buy the new processor, you can buy radial Olympus. But when you have less money, in which of the technology you would invest first when you want to have access to smaller lesions in the peripheral part of the lung?
The radial probe is the most important key point, because you can do nothing with that. Of course, planification helps you, shorten time, be more confident for the beginning. I think at the beginning for educational, the planification can help you. But after, if you have in routine practice, you see that you reduce the time of the procedure. But mini probe is the real time. You see what happened at the peripheral. So, I was educated by Philippe Astor, who's there, and now for the PRORA, you can't imagine to put a needle in the PRORA without having a look with a bus before. So the ultrasound is really important to see, okay, if I put a forceps, I will never put a forceps at the distal peripheral if I don't see what happened with my ultrasound.
Yeah, I totally agree. And especially what you also mentioned in your talk, and when you go to the literature and when you see what our colleagues from Japan publishing, when they're using the ultrasound bronchoscope and the radial EBUS probe, it's really amazing what you nowadays with the small 3mm scope with a 1.7mm working channel can get access to, and with the radial EBUS you can confirm it, and you can take the brush or the curettage or whatever you want to make the diagnosis. So therefore I think the new scope generation and the EBUS is really something which makes it, even from a cost perspective, implantable in your daily doing.
Yeah.
So when you plan a case, when do you decide to use the Veran system, and when you just use having a view on the CAT scan and using the EBUS, the radial EBUS for guidance?
I think each unit have to adapt themselves. For me, it's really easy because we're doing all the procedure. If we miss it, the radiologist will help us. For example, for the 15% or the 20% maximum that we can't reach, the radiologist will reach it. So for us, the peripheral is a routine because we didn't select the cases, because if you have a lesion, we're doing diagnosis for peripheral and stratification, but we're doing in the flow rate. It means the patient comes, the scan is including in the pack, so we're just doing the planification just before the procedure. So it's 5 minutes before, and we just follow. I know it's difficult, it's like the Waze system for your car. It means now it's difficult to take your car without seeing what's happened on Waze, the traffic jam, the police, or the best road. And now it becomes the same for the bronchoscopy. So I put the planning, I just do it, I follow him, just check before for the proximal. I doing the biopsy, I succeed or not, and then I doing stratification. So in less than 20 minutes, you can have a lot of answers. So I think planification, you can include it in your routine practice really easily.
Yeah. I think especially when you use a planning software up front, you learn a lot about the anatomy of the bronchial system. So when we're doing that by our juniors, they're using that quite often in every case, but then when they're doing that, they understand in a better way how to target the lesion, and then you really see how the use of that planning is going down, and they only using it in lesions below 3 centimeters. So it's really something where you also learn a lot how you should do a bronchoscopy when you use the planning as a guidance system for your daily doing. Okay, Bruno, thanks a lot.